talked about the discs as jelly donuts. When you first get jelly donuts, they're nice. Press them a little bit, they bounce back. The older they get, they've been sitting out a couple days in the break room. They've been sitting out a week. They don't give so much anymore, and the jelly starts squirting out in all sorts of weird ways, and it never comes back.
You're listening to the Ethos Athletes podcast, where we believe that your health is the number one resource you need to accomplish your dreams. My name is Dr. Matthew Hernandez, and I'm a physician dedicated to helping my patients maintain their active lifestyle and continue doing what they love. I'm sitting down with other experts so that we can provide our listeners with the knowledge they need to improve their health and live their best life. Hey everyone, this is Dr. Matthew Hernandez, and you're listening to the Ethos Athletes podcast, where we provide resources to help you maintain and keep your active lifestyle. We are continuing our low back pain series. In the very first episode, we discussed the common myths behind low back pain and dove into why some of those myths are wrong and corrected them. In the next few episodes, we're going to be discussing some of the causes of low back pain, mobility deficits being this episode. The following episodes will be referred pain, radiating pain, and movement coordination impairments. We'll be explaining what each of those are as we go. For this particular series, we brought on two special guests that specialize in low back pain. The very first one is Dr. Tom Padilla, who is the owner of the Doctors of Physical Therapy. The second one is Dr. Morgan Massingale, who is our spine health specialist here at Ethos. So Dr. Tom, Dr. Morgan, welcome back to the show.
Thanks for having me back.
Thank you so much.
We went over quite a bit in the last episode where we discussed a few different myths regarding low back pain. Some of those being, how accurate is imaging when we're diagnosing low back pain? Is the low back pain always going to be related to what the image shows? What happens when you quote unquote throw your back out, and a number of other myths outside of that. And today we're going to really dive into mobility deficits and how those cause low back pain. So Dr. Tom, can you kind of give us an idea of what mobility deficits means, and then we'll go in from there?
Yeah, absolutely. So when we're talking about a mobility deficit, generally you're thinking like an older, stiffer spine or just somebody who's had back pain for a long period of time. What it means is that it's usually referring to the joint. The joint has become stiff and immobile. There are these things called facets in between each of your vertebrae, and those facets are what need to glide together in order to have you be able to flex forward and backward and side bend side to side and rotate. So usually when we're talking about mobility deficits, we're talking about those joint surfaces have become a little less mobile. They're stuck together, and or the capsule that surrounds them isn't opening enough because there's been inflammation in the capsule or scar tissue is built up around that joint that just does not allow it to open. So these individuals will have pain that comes from the actual joint being compressed most typically.
So when we're looking at set joints, you talked about how they glide. Dr. Morgan, can you kind of explain, if someone were to go and Google an image of spine itself, can you describe what they're looking at with regards to a given vertebrae and what the overall function of each vertebrae is? And I think that'll help us kind of look into mobility deficits a little bit more.
Sure. So when you're looking at each level of the spine, there's a number of tissues to consider. You have the bony tissue, which I think most of us are familiar with. That's, if you have the skeletal model hanging in your physician's office, which I have my tiny spine that I like to pull out from time to time. That's what you're looking at, right? So there is the vertebral body, and in between those, you have the discs. Most of us are also pretty familiar with discs. A lot of times your pain is explained away with disc herniations, disc ruptures, that sort of thing. It is the soft tissue that connects each of those levels. On the back side, you have the facets that Dr. Tom just mentioned, where each of those levels kind of come together and allows that range of motion that we really think of in the low back. So that forward bending, that extension to the back, that side-to-side motion and rotation. The soft tissue that surrounds that is equally important. So the ligaments that actually hold all of those bony components together, looking at the integrity of those is really important. Are they too lax? Are they too stiff? As we age, sometimes those begin to calcify and almost turn into bony-like structures themselves. So has that happened? And then there's the actual nervous tissue. We all think of the spine as the actual spinal cord that's running up and down from the brain down out to the body. But then you have the spinal nerves that actually exit and make their way out to the periphery. So they're sending all of that signaling information in two different directions, right? You've got the motor commands coming from the brain out to the body, and then you also have the sensory input coming from the body back up towards the brain through those spinal nerve roots.
Let's start with the vertebral bodies itself. When you're looking at an x-ray of the spine, this is what people are interested in, is looking at the vertebral body. What are some of the things that can happen with that? I know, like when you go to a chiropractor, they could say you have like some narrowing of the space in between that area. They can look for rotations. Orthopedic surgeons will obviously look for the narrowing of that space as well. Can you kind of describe, Dr. Tom, like what are we looking for in those images when it comes to mobility deficits?
Usually when they're looking at the space between the vertebral bodies, if the disc has lost height, and typically this is going to be described on an MRI as a slightly bulging disc, or once you start to lose height. But what people have to remember is that the discs are made of 70% water. So you take something that's made of 70% water and you compress it over a long enough time, it's going to look like it's bulging. Bulging isn't anything that anybody over 30 does not have. So to say that another way, everybody over 30 has bulging discs. As the discs start to lose height, the space where the nerves actually come out of the foramen in between the vertebral bodies can decrease. And as such, the facet joint also becomes a little bit more compressed once that disc height has started to diminish. The other things that can happen to a vertebral body is you can get slippage. You can get what's called an anterior or spondylolisthesis, where because of muscular instability, typically, and ligamentous instability, the vertebral body will actually start to migrate either forwards or backwards, which is a little bit more concerning when you get to the higher levels because it does cause things to encroach on the nerve roots and on the spinal canal.
When we're looking at the facet joint, like the slippage that you talked about, that's going to be from a muscular component. Those disc bulges is going to be from, in general, loss of water with it. When we look at the restriction, how can someone tell if they have a restriction in their facets? Or maybe they can't tell directly, but what we look for on an exam that can kind of give us an idea of that's happening.
A relatively easy way to tell is if you have pain anywhere in the low back down to the upper glute, or even a little bit lower into the upper thigh that's made worse by side bending. So let's say you have left-sided back pain and you side bend to the left. That increases your pain on the left side. That is typically going to be more of a facet issue, or if you extend. So if you stand and push your hips forward and bend your back backwards, if that reproduces your pain as well, both of those movements close that left facet. So if your pain is caused by joint compression, that's going to elicit or bring it on.
And this was something that Dr. Morgan, you went and found on one of the patients that I was looking at. She had low back pain. Again, you're the specialist when it comes to that. So I just brought you in for that, and you were able to pick that up, within like 30 seconds.
Yeah, facets are very commonly irritated just for the reasons that Dr. Tom was kind of mentioning. As you get those, that loss of disc height, that's one of the joints that has room to give and it doesn't like to give it.
Yeah.
Surgeon that I shadowed for a while in training kind of talked about the discs as jelly donuts. When you first get jelly donuts, they're nice and they're juicy, and press them a little bit and they bounce back. The older they get, they've been sitting out a couple of days in the break room. They've been sitting out a week. They don't give so much anymore, and the jelly starts squirting out in all sorts of weird ways, and it never comes back, right?
Yeah.
Like it doesn't magically become a brand new jelly donut anymore. And so that's a good way to kind of think about what's happening in the discs with dehydration and just age over time.
What are some of the things that can help someone that has that issue where they bend to their side, it makes their pain worse? What are some things that can be done or some things to consider as far as treatment and not only for short-term help, but long-term help as well?
Yeah, so there's a number of ways that you can kind of approach this. Acutely, just getting patients out of pain, you can address the medial branches of the dorsal nerve roots as they come out, because that's actually the nerve that is innervating that capsule of that facet and sending the pain signal back upstairs to the brain, letting you know that you're having pain. Addressing those nerves directly with either, allopathically, they'd be looking at steroid injections or ablations. You can do a really dilute dextrose solution that actually we refer to as a perineural solution that will help kind of reset that nerve and get it to calm down. That being said, one of the things we talked about in the last episode is making sure that you're setting the patients up for more long-term healing and long-term benefit, not just kind of masking symptoms. So acutely getting them out of pain, obviously really important, because if they're in a flare, they're not going to be able to do some of the physical therapy work. They're not going to be able to do activities of daily living, that sort of thing. But you really do need to go in and address why that capsule is aggravated. Are their muscles misfiring? Are their ligaments unstable? Is it a combination of those things? Figuring that out and addressing those is going to be of more long-term benefit.
On our end, it comes to, well, why are the ligaments unstable? Is it habitual postures or ways of moving? What muscles are not firing appropriately that have led to either instability in the joint, which results in increased muscular tension and then causes grinding in the facets? So you really have to kind of figure out what the coordination and movement pattern dysfunction might be that has caused that. And sometimes it can be as simple as just habitual postures throughout the day. That has loosened your ligaments to the point that your muscles overcompensate. And when they overcompensate, you're going to get compression. And when you get compression, you get joint grinding. And when you get that grinding, it becomes arthritic, tracing it back to root cause and making things as simple as adjustments to somebody's workstation or seated posture sometimes can make a big difference. And other times it's more complicated because they have a long history of multiple injuries, which you kind of have to peel the layers of the onion back and figure out what the resultant movement issues are.
Outside of mobility deficits from a facet restriction, what other restrictions can we have with regards to low back pain itself?
Like what can be immobile?
Yeah.
The muscular tissue can be immobile and not willing to stretch or slide very well. The fascial tissue can become a little bit restricted, and then you've got nervous tissue. So actually, your nerve, once those joints are compressed, all the nerve roots that come out of your back and then form to make the big sciatic nerve that goes down your leg, if you've got restrictions in the spaces where those little nerve roots come out, that's going to show up in your sciatic nerve not having as much mobility as it should, which means that when you're doing a lot of your normal daily movements, you are actually pulling on your sciatic nerve, which can increase nerve pain.
I know we had a discussion earlier with regards to looking at like fascia as well. You want to talk a little bit about that?
One of the things I saw a lot in my training was patients that had already had failed back surgeries. With any type of surgery, you have scar tissue as the body tries to heal around that incision site and whatever was done there. Scar tissue, when it first gets laid down, is laid down in a very kind of haphazard pattern. Your body's just trying to fill in the void, right? And then you have remodeling that happens in I think up to a year after the original injury. You know, the lines of tension and the way that your body moves kind of pulls those connective tissues, hopefully back into the right shape and pattern. Unfortunately, if we're not actually focusing on that and no one's addressing any level of that scar tissue, it never remodels and it gets stuck down and it really kind of impinges on a variety of tissues. It can impinge on the actual nerves. It can impinge on the muscles and the way that they're gliding. So that's something that really needs to be assessed, especially with nerves and looking at like the way that they come up into the subcutaneous tissue, making sure that the nerves through their whole path from the spine out to the periphery are free to glide. We kind of think of nerves as static. They're not really. Every time you stretch out your arm, your nerve has to kind of move and glide to accommodate that motion and the other tissues that are moving around it. If it's getting caught up at any place along that track, it gets angry.
Okay.
And so you really have to make sure that it can glide, and addressing both the connective tissue and the surrounding musculature can be important there.
Okay. I'll ask you about nerve glides in a second, Dr. Tom. Follow-up question for you, Dr. Morgan. When people think about scars, I think most people will think about a scar being as this very superficial, like just on the skin surface, but it actually goes deeper than that, correct?
Yeah, it goes down through all of the layers which were cut or damaged in the original injury. And so it's not just that surface layer that you need to be looking at, but looking at the surface layer can tell us what's going on deeper. If you just do some simple assessments, kind of pulling the skin in different directions around that visible external scar, you can see where it's able to move and where it's not able to move and what restrictions it's formed and how tied down to the underlying tissue it is. And there's a variety of ways you can go in and kind of address that.
You mentioned in your training, you had you saw a lot of patients who failed back surgery. Was the failure ever due to the scar formation after the fact, or was there something else that happened during the surgery that made it fail?
Honestly, it's a variety of things. I think for a number of patients, it was being referred to surgery because they hadn't been assessed by someone that had other options to give them. We talked about that last episode. I didn't see a lot of any sort of like malpractice or anything like that, really. Yeah, mostly just kind of wrong indication, sort of.
You failed the epidural, you failed the nerve ablation, so let's go ahead and cut it and see what happens. Yeah.
Very logical.
Yeah, for sure. Now, nerve glides was something that I don't think I had heard of until I started shadowing you, Dr. Tom. And then, it's a whole like PT thing.
It is a PT thing.
That we weren't taught in school. I've
got lots of things.
Yeah. I've heard PTs reference it more than anyone else. Dr. Morgan kind of explained what nerve gliding is in general, but how would someone know they have an issue with this? Like there's some things that you do in your office that kind of test to see if this is a problem.
There are a couple orthopedic tests that we use. One's called the slump test, and then there's upper limb neural tension testing. The slump test you could probably do on your own, but the upper limb neural tension testing is a little bit more difficult. What a nerve glide is essentially there are certain movements at each joint that pull the nerve away from your spine, and then if you do the counter movement, it allows it to go on slack and go back towards the spine. By extending my wrist, I can pull the nerve away from my spine and towards my hand, and I can also let that nerve go towards my right hand by bending my head to the right. So if I slacken that nerve in my neck and allow my hand to pull it out to my right, that whole nerve glides out to my right. And then if I bend my head to the left and slacken my wrist and bring my wrist into flexion, I can glide that nerve back towards my spine. So it's really just doing repeated movements like back and forth that helps the nerve to actually start to move better through the tissues.
When you're looking at treatment of this, it's the repetition of making sure the tunnel, I guess, for lack of a better term, is able to go in. The nerve is able to glide within that tunnel.
Yep.
Right?
Yep.
If it doesn't respond to repetition, I know there's stuff that we can do on our end from an injection standpoint, which is hydrodissection.
Yeah.
Do you want to discuss a little bit about what that looks like?
Yeah, absolutely. So with nerve hydrodissections, we take and we image the nerve under ultrasound and actually go in with a solution and kind of release the nerve from the surrounding tissue. So this is something that it takes a fair bit of skill to do because you don't want to actually touch the nerve with the needle.
Yeah.
That's very uncomfortable. And typically you're having to hit a few different spots on the nerve. So like Dr. Tom was kind of just talking about we're going to talk about the median nerve in the arm right now. It can kind of get caught up in a few different places in the track and then present as like that, traditional carpal tunnel that we may think about. And a lot of times you'll just go in and people will try to do nerve releases right at the wrist. I think more people are moving to doing hydrodissections because it's a lot less invasive than the traditional release surgeries that you were looking at previously. But addressing right at the wrist isn't necessarily going to free up that nerve and give it the amount of mobility that you're actually looking for. So with nerve hydrodissections, hitting several places along that track to make sure that you're really getting that sheath free and allowing that motion.
So the sciatic nerve is definitely one that we can do a hydrodissection on.
Yeah, especially, we were kind of chuckling about the term Piriformis Syndrome last time, right?
Yeah.
But that is kind of where that sciatic nerve can get kind of matted down a lot of times, is right through that area, getting down to that nerve and kind of disengaging it from whatever's compressing it and causing that irritation can be really beneficial for patients.
What other nerves are common with regards to being restricted in the low back that can cause that low back pain in general outside of the sciatic nerve?
So you have your sciatic. You can also address that up at the kind of spinal nerve root level with things like transforaminal epidurals. And then you have, I like to look actually at a lot of the subcutaneous nerves. So with perineural type therapy, you're looking at the nerves that are running right underneath the skin above that muscular layer. There's a lot of connective tissue in that area, kind of allowing the skin to glide over the musculature. There's a lot of motion that you have, especially in the hips, right? Because you go from seated to standing. That's a pretty big range of motion that joint is making. So if that connective tissue gets matted down, stops allowing those subcutaneous nerves to move, it can actually pretty well mimic SIJ pain because it's right over those areas, those superior and medial conial nerves. If they get kind of matted down in that connective tissue, you can have pain referral patterns that really look like sacroiliac joint pain.
Have you seen any other nerves outside of that on your end, Dr. Tom?
No, I think we covered them all.
From a muscular standpoint, what muscular restrictions can occur?
In the lumbar spine?
Yeah.
You call it, right? You could have lat mobility restrictions. You can have any number of the paraspinal muscles restricted. The multifidi can be hypofunctional. The QL can be overactive. You want me to name them all? Longissimus thoracis, iliocostalis.
So maybe the more important question, maybe following that, we discussed this to some degree in our first episode when we talked about low back pain myths. But one of them is going to be, if we have a restriction, a muscular restriction, it's usually a tightness that's occurring. The question that doesn't often get asked is, why is the muscle tight?
Right.
Can you discuss a little bit about some of the reasons why muscles are tight and why just going and simply relaxing a muscle that could be causing the back pain isn't always enough?
Absolutely. So muscles get tight for a few different reasons. Some of the more basic ones are dehydration or overuse. So if somebody is competing at a high level over and over again and never allowing their body to rest. Another one is compensation. So if there are weaknesses in muscles that are supposed to be stabilizing the joints, the larger muscle groups will often be the ones that come on too much. So over time, they'll get stiff and hypomobile, or injury, right? So anytime that there's an acute injury to anything in the lumbar spine, what the other muscles do, which is good and bad, is splint. And over time, that splinting pattern actually becomes the new pattern because that pattern becomes stronger than your old pattern. So your brain starts using that pattern and over time forgets how to use muscles like your multifidi or other stabilizing musculature. That can end up being the cause for why you can stretch, or you can use a lacrosse ball or foam roller and you can get a massage, and it never seems to help for more than a couple of days or weeks at a time.
I often see that a lot of people, when they come in and have said, oh yeah, I do massage, doesn't get any better. I've done injections, like trigger point injections, doesn't get any better. And that's usually because, they're treating just that tight aspect. They don't go any further. So there's no further evaluation outside of that. So going and strengthening the weak muscles, stabilizing the area will decrease that tightness. And that's what the long-term solution is, correct?
Correct. Yeah, because you're actually addressing the reason that muscle's tight in the first place.
With muscular restrictions, for people to know that they have it, is it that they just have tight muscles, or is there more to it than that?
It's a good question. I mean, everybody's symptoms are going to present differently. It can be achiness. It could be loss of range of motion. It could just be constantly feeling uncomfortable in the area. It could be an area that when they get stressed, they always feel an increased sensation. Everybody's got a little bit of a different presentation when it comes to that. Most people with this issue have a low level of back pain on a daily basis, but never really do anything about it until they have an event, like they throw their back out or they really, jam a joint and can't move for a couple hours. And that usually scares them into doing something.
Yeah.
Something about that low level that they've been ignoring.
That's fair. Just to backtrack really quick, I realized we didn't talk about ways to address the fascial restrictions with scar tissue.
So there is a number of ways that you can do that. Some of the non-invasive, but actually kind of looks a little worse from the outside. You have some scraping techniques that are really good for connective tissue, like traditional gua sha, which is derived from traditional Chinese medicine, where you actually take a hard tool and just really help break up that connective tissue and kind of show it the proper lines that it should be laying down. I said it kind of looks kind of bad from the outside because it does cause bruising for most patients. Cupping can actually help with some connective tissue, break it up. Doesn't really show it how to remodel necessarily. You definitely want to be doing that in conjunction with something else. I know we all want to be Michael Phelps and just run around with our giant hickeys on our back. But
cool, yeah.
there's a lot more work that goes in there. And then you have some hydrodissection techniques where you can actually go in with a needle and kind of use fluid to break up really old and stuck down connective tissue that may not be responding to more manual external techniques.
So we've discussed muscular restrictions, fascial restrictions, nerve, and then talked about facets. Are there any other bony restrictions outside of that?
That I know about?
No? Okay. Ligamentous restrictions. I would imagine that the only ones would be like a calcification.
Yeah.
You want to discuss that?
If you start to have calcification within the ligament, that's obviously going to prevent it from moving in the ways that it's supposed to. Really, the only technique that I know to kind of address that is injection therapies, getting in there with like a PRP or, an autologous stem cell autologous stem cells to really help the body remodel that tissue and address that calcification.
Yeah, so we covered the vast majority of mobility deficits that relate to low back pain. In the very next episode, we're going to be discussing referred pain and how that presents with regards to low back pain, obviously. Dr. Morgan, Dr. Tom, thank you so much for being on the show.
Thanks for having me.
Everyone, thanks for listening, and we'll catch you on the next episode.
Do you or someone you know experience joint pain? Our team at Ethos Sports Medicine loves to work with active individuals and help them avoid surgery and pain medications, eliminate joint pain, and stay active. Ask our team how you can get more information on our unique approach to joint pain so you can continue doing what you love.